All right, so as an introduction, my name is Konstantinos Linos, and I'm a pathologist at Memorial Sloan Kettering Cancer Center in New York. And the topic will be breast core needle biopsies, and what are the guidelines, what are the consensus or the gray zone in terms of what do we do in terms of management and the possibility, the likelihood of upgrade in the subsequent excision. Right, so let me just fix this a little bit. So there are different ways you can do core needle biopsies using image-directed guidance methods. So you can actually use a stereotactic mammography. You can use an ultrasound, as you just heard, or a magnetic resonance imaging. So there are different imaging modalities, and the core needle biopsies are the standard of care for the initial evaluation of non-palpable breast lesions. There are different core needle biopsy devices. You can use a spring-loaded, as you've heard already, where you discharge a cutting needle into the breast tissue and you sample the mass. Or you can use vacuum assistance, which is used when you do that. You obviously have substantially larger samples. You have a collection of numerous contiguous samples with a single needle insertion, and is used to sample microcalcifications. Now, there are a few things when you do a biopsy that you need to put that in the requisition form so your pathologist knows about. And it's very crucial, and all this info, they have to be written by you or the nurse so you can inform your colleague so you can make an accurate diagnosis. So you have to write, obviously, the laterality and the location of the targeted lesion. You have to write the indication for the biopsy. What are you biopsying? Are you biopsying a mass? Are you biopsying microcalcifications? Are you biopsying architectural distortion on a non-mass enhancement on the MRI? You have to put the differential as a radiologist. What is the differential? The level of radiologist suspicion, the so-called BI-RADS category. How did you do it? The image guidance methods. What size of needle did you use? And the number of cores obtained. So all these, you have to put that on the requisition form. And if you do a biopsy for microcalcifications, you should do the following. So the specimen should actually have a radiograph, be obtained by a radiologist when you do the biopsy. And then you have to separate the cores that they have the calcifications and submit these separately from the cores that they don't have the calcifications. And ideally, you have to send with the specimen the radiograph so the pathologist can actually see the radiograph, right? So these are steps that are very important so you can get a more accurate diagnosis. Now, I'll start a little bit backwards, and instead of talking first for primary breast lesions, I'll say that obviously the great majority are primary lesions, but you should never forget that you actually can get a metastasis to the breast. So some of the lesions that you're going to biopsy and you think is breast carcinoma, they actually may actually be a metastasis. It's a very small percentage, but it's a real life, and we see that. In the big centers, it's even more frequent. And the features that raise concern when I see a biopsy for a metastasis to the breast is if I don't see an in situ component. The histologic appearance is quite different from a breast primary carcinoma. If I see extensive lymphovascular involvement with little or no associated stromal invasion, that is a red flag that I'm seeing in a metastasis. Or if the patient has a history of concurrent carcinoma on the other side. And carcinomas that look very epithelioid under the microscope, but every epithelioid malignancy, it's not epithelial, right? Epithelial means carcinoma. So it could be a metastatic melanoma, epithelioid angiosarcoma, anaplastic large cell lymphoma, etc. So the other thing is that when you do a core needle biopsy, not all lesions are actually from the breast parenchyma. So you can actually sample something that is in the subcutis, in the subcutaneous tissue. For example, that's very frequent. You see angiolipomas there. Or you can sample a breast skin lesion like a dermatofibroma or just a simple cyst. And just to give you a few examples, these were core needle biopsies for presumably primary breast carcinoma, but they end up to be something different. Why? Right. They end up to be something different. Here is a metastatic, do I see here, let me show my laser point. I don't know why it doesn't show up. Oh, here it is. So here was a metastatic melanoma, or here was metastatic medullary thyroid carcinoma, or metastatic lung adenocarcinoma, or even you have a primary breast lesion, which was a secondary post-radiation angiosarcoma. So weird things can happen, so you have to have that in your mind. Now, let's switch gears now to the primary breast lesions, which is more common, obviously, and there are a few problematic areas, right? So the problematic areas is that many studies, they, let me just see why I don't, sorry. Yep. So that there is the evidence base to guide management of these breast lesions, such as ADH. We're going to talk about ALH, lobular carcinoma in situ. It's not well developed. All right. So the public literature that we have, it's almost entirely of small single institution retrospective studies, which is very difficult to have good data to make conclusions. And there are lack clear criteria for excision. And of course, we don't have good long-term follow-up for these lesions, that they are not excised and what happened to them. But and this has changed dramatically the last 3 decades or so, because we actually detect these lesions, ADH, ALH, LCS, more frequently because of the methods. So we use vacuum-assisted biopsies, and we have better imaging modalities, etc. Now, you see a lot of different studies out there that they give a very wide range of upgrade of these lesions, from 1% up to 60%. And when you see these numbers, something is off. So the problem is that many of these studies, they lack careful radiological pathological correlation. And if you're going to get one message from this lecture, is that it's imperative to have radiological pathological correlation, as I was saying yesterday, because if you don't do that, then it's going to be a recipe for disaster. Now, the criteria for the diagnosis of atypical ductal hypoplasia, atypical lobular hypoplasia, and LCIS were actually established in open biopsies, which was in the pre-mammographic era, and that is a problem when you apply these criteria in core needle biopsy, that they represent a much smaller sample, obviously, than the area that is identified in the mammographic studies. And the other thing is, what do you define as upgrade? This is all over the place in different studies. Some studies define upgrade as carcinoma in the subsequent excision. Others define the finding any worse lesion than the one you see in the core needle biopsy. So there is a lot of different things out there in terms of the literature, and but we're going to talk about all these things. And in general, the non-malignant breast lesions that are frequently associated with upgrades to carcinoma and excisions, of course, atypical ductal hypoplasia, it's actually the higher percentage, and then ALH is much lower, so we're going to talk about LCIS, and then we have other problematic lesions we're going to talk about. When you see flat epithelial atypia, or get a report with flat epithelial atypia from your pathologist, or papilloma, radial scar, or a mucocele-like lesion. In terms of the atypical ductal hypoplasia, what is it? Is an atypical intraductal epithelial proliferation that, as I said yesterday, has features that resemble low-grade DCIS, but it doesn't meet the criteria for low-grade DCIS. And the criteria is mainly quantitative, because qualitatively, morphologically, it looks exactly like a low-grade DCIS. The criteria for making the diagnosis morphologically are based on a combination of cytological and architectural factors, and the expected rate of a diagnosis of ADH in core needle biopsy is approximately 3%. So if you send a lot of core needle biopsies to your local pathologist and you get a way higher number of that, then there's a problem. So the expected rate is about 3%. Now, I don't expect to read all that stuff, but I wanted to see the numbers in all these different studies, so many years of upgrade rate when you get an atypical ductal hyperplasia. And they're all over the place. There's from 0% up to 46%, up to 62%. So when you see these numbers, then there is a problem in terms of methodology and design of these studies, because you can't get all these discrepancies, right? All these different numbers in terms of upgrade. Now, the key here is radiological pathological correlation. When you actually look at these studies more carefully, when they have a very strict radiological pathological correlation and evaluation of the extent of the remaining calcifications, then the upgrade to DCIS or invasive carcinoma ranges approximately 10 to 20%. So that is a more accurate number in terms of the possibility of upgrade when you get a diagnosis of atypical ductal hyperplasia. The higher upgrades, there are a number of factors that have been associated with. There's the variety of mammographic features. You have a mass, or you're having a linear branching calcifications. Technical factors, what kind of needle did you use? Of course, if you have a small God's needle, then the upgrade is going to be higher. There are studies that have shown that there's no significant, the upgrade between a larger 9 gauge and versus an 11 gauge vacuum-assisted stereotactic core biopsy devices. There's not much difference in terms of the upgrade. However, when you use a ultrasound 14 gauge device, it's actually more likely to be upgraded because the needle is much smaller. If you didn't use a vacuum assistant, or if you have an incomplete removal of mammographic lesions, these are factors that are associated with higher number of upgrades. And of course, what the pathologists show on the slide, if you have extensive lesions or a greater number of foci, if you have a micropapillary pattern or it's bordering to DCIS, then all these factors are actually associated with higher upgrades than your average 10 to 20%. So in terms of the upgrade, so it's still, even if you have fewer than 3 foci, and even if you have actually removed calcifications completely, there's still studies showing that the upgrade of ADH to DCIS or invasive carcinoma is still up to 12%, which is an unacceptable number. And just to show you a couple of pathology pictures, this is a typical case of DCIS, where you see a very monomorphous population with atypia, and you have these bridges and the micropapillary pattern, and this is more solid component. So this is how a DCIS look or an ADH looks like. And as I said, they look exactly identical morphologically, but the distinction between the two is quantitative. So if you have the diagnosis of low-grade DCIS is usually restricted when you have at least 2 duct spaces or an area which is more than 2 millimeters. If it's less than that, it's an ADH. And if you can really, in the borderline cases, you can really make a distinction between the two, then many experts report this a typical intraductal proliferative lesion. So people have looked at trying to do some nomograms in order to predict the likelihood of upgrade in atypical ductal hyperplasia. And in this study, they used 203 consecutive cases of ADH in core needle biopsy, and still the overall upgrade was 28.1%. They use different variables here. You can see patient's age, mammographic status, hormonal therapy, method of detection, etc. And even if you do that, even in patients which were determined by the nomogram to be least likely to experience an upgrade as assessed by the nomogram, they still have a possibility, a rate of about 8% to be upgraded. This was a paper from MD Anderson Cancer Center, where they reported recently a series of 125 women who had ADH on core needle biopsy, and they managed these patients with follow-up rather than surgical excision. On all these patients, the criteria for inclusion, they had to have less than 3 foci of ADH, no mass on imaging, and more than 50% of microcalcifications should have been removed. So these were actually inclusion criteria, and the median follow-up was 3 years. With a median follow-up of 3 years, the breast cancer that was detected on this woman was about 5%. So based on this data, at the current time, based on the rate of underestimation of DCIS, most experts recommend that you get patients with ADH on breast cord needle biopsy excised. There is some cases where you have a very small volume of ADH, and then you don't have any remaining calcifications, and there is a multidisciplinary group that you may actually observe these patients, but this is a very small percentage of these patients. For the great majority, when you get a diagnosis of ADH of breast cord needle biopsy, this patient should be followed by subsequent excision, because the rate of the subsequent DCIS or invasive carcinoma is unacceptably high. Moving on to atypical lobular hyperplasia, which is a proliferation of monomorphic epithelial cells. We have a cellular dishesion, as we show a couple of pictures, and they have to expand less than 50% of terminal duct lobular unit. If it's more than 50%, we're talking about LCIS. It is usually an incidental finding, and you see that in less than 1% of patients with cord needle biopsy, and they can actually rarely be associated with microcalcifications. And this is a classic case of LCIS. I'll show a couple of pictures, and if you do it, coherence is going to be negative, because these tumors have these neoplastic proliferations have somatic alterations of the CDH1 gene, which is the EAT-cadherin gene. Again, this is a series of studies that you can see here that the upgrade rate is all over the place, from 0% up to 67%. So not all these studies are reliable to make actually reliable recommendations. But when actually get quality studies that they have done a strict radiological, pathological correlation, the number draws very, very significantly, and actually in cases where have a very careful radiological pathological correlation, the upgrade is so low, it's approximately less than 2 to 3%, right? So though that is a more accurate number. So many institutions now recommend observation of patients who have incidental atypical lobular hyperplasia diagnosed on cord needle biopsy, that they lack other indications for excision. So you can watch this patient and you don't have to go back to do an excision like you have done if you get a diagnosis of atypical ductal hyperplasia. This was a 48-year-old woman, had a history of bilateral fibroadenomas, to give you an example, who presented with a new left breast mass, was about 2.1 centimeters, was partially circumscribed on mammogram and on ultrasound, and overall was felt to be by the radiologist a BI-RADS 4A. So they did an ultrasound-guided biopsy, which showed fibroadenoma. This is a beautiful classic morphology for fibroadenoma, but also showed an incidental finding of LCIS. And here is EAT-cadherin staining, which showed loss, reduced expression, so less brown. So this was an incidental finding of a focus of ALH in the background of a fibroadenoma. So the diagnosis of fibroadenoma was radiologically concordant, and with a single incidental focus of ALH in this patient was offered surveillance as an alternative to immediate surgery. So you could actually watch this patient and not do anything else. Lobular carcinoma in situ is an epithelial proliferation that is cytologically similar. It looks exactly the same morphologically, but you have an expansion more than 50% of the terminal duct lobular unit. And lobular carcinoma in situ is identified in approximately 1% of cord needle biopsy. So if you get way more than 1%, then that's a problem with your local pathologist. And it's often an incidental finding, but it may actually be associated with microcalcifications. And again, the same pattern here. If you see all these studies, the upgrade rate is all over the place. But actually, when you have studies, quality studies, that they have a very careful and strict radiologic pathological concordance, the upgrade rate drops to less than 4% in terms of subsequent carcinoma in the subsequent excision. So the likelihood of developing carcinoma, and it's less than, it's within 3 to 5 years, is actually in many cases actually 4%, even less in some areas. And some studies you had a carcinoma very close to the initial core needle biopsy. So this should not have been included as an upgrade, because if it's too close, was probably a missed carcinoma anyway. So it's not really, by strict criteria, an upgrade. So it's really low. That's what I'm trying to say, even for LCIS. And very recently, a couple of years ago, the data of the Translational Breast Cancer Research Consortium were published. The results of multi-institutional trials. One of them was the TB-CRC 020 that looked about determining the upgrade rates of lobular of ALH, and the upgrade rates for classic type lobular neoplasia was 3% based on local pathology review, and actually if you had a central pathology review, so more expertise, is actually was dropping to 1%. So very low percentage of upgrade in patients with ALH or lobular carcinoma or LCIS. So based on these findings and data, the many institutions now offer patients with lobular neoplasia on core needle biopsy and concordant imaging findings the option of follow-up rather than do a surgical excision. And this approach is currently supported by the National Comprehensive Cancer Network in the United States and the American Society of Breast Surgeons. So if you get a patient with LCIS or a typical lobular hyperplasia, these patients can be offered follow-up and not a subsequent excision. However, I want to stress that these apply for classical lobular neoplasia. If you have subtypes such as pleomorphic LCIS or SCIS with comedial necrosis, these are different. These are more likely to be associated with suspicious microcalcifications. They're less likely to be incidental. And actually the upgrade is actually much higher. So if you get a diagnosis of pleomorphic LCIS or LCIS with comedial necrosis, then a surgical excision is required, and these patients should not be offered a non-surgical approach. So to summarize, if you get a patient with a typical ductal hyperplasia, surgical excision is now the recommendation, especially if you have a very small volume of ADH that has been completely excised. You don't have any calcifications, remaining calcifications, so it's a small percentage of patients that actually you can watch. If you get a diagnosis of a typical lobular hyperplasia or LCIS, these patients can be offered observation unless there is discordance. Then these patients should get an excision, but we're talking about cases that patients have concordance between pathology and radiology. But if you get a pleomorphic lobular carcinoma in situ or a ductal carcinoma in situ, then these patients you offer excision. Although there are active surveillance trials now, what do we do with patients we have a low-risk DCIS, and trying to find out which patients can be safely watched rather than followed by a subsequent excision. There is a recent study reported the development of machine learning algorithms based on clinical features and pathologic features that they were extracted from the pathology report and tried to predict which patients' upgrade rates in women who have high-risk lesions identified on core needle biopsy. And it actually was pretty amazing. This model was developed. They had about 667 patients with high-risk lesions. They trained the algorithm and then applied that on an independent set of 335 high-risk lesions. And actually using the algorithm model, there was only one cancer that was missed, so about 2.6% out of the 38. It was pretty significant results. So it's coming. So machine learning algorithms and trying to predict which lesion is going to have an upgrade or not merits further evaluation, and I'm pretty sure there's a lot more studies will coming up. So in a recent, and so these numbers that I gave you is about the risk of upgrade in a single patient in the immediate management. But of course, if a patient gets a diagnosis of ADH or ALH, they have a cumulative breast cancer risk in their lifetime that is approximately 25 to 30% in 25 years, right? So this is the risk that the women have to develop breast cancer in their remaining 25 years. But the upgrade rates, and this is about what is the possibility, what is the rate, what the chance, the likelihood to have a carcinoma or a DCIS in the immediate excision of these patients, right? So this is the overall risk in lifetime. It's a different thing. In terms of LCIS, the cumulative breast cancer risk incidence for patients diagnosed with LCIS was approximately 26% in about 15 years. But of course, there are other problematic lesions you can get in core needle biopsies, and we'll talk a little bit about that. Flapped epithelial atypia, get a diagnosis of a papilloma, radial scar, as we talked yesterday, or a mucocele-like lesions, and what do you do? What are the data? So the WHO classification for columnar cell lesions, they are being divided in three categories. You have columnar cell change, columnar cell hyperplasia, and flat epithelial atypia. And these lesions, they're frequently present with microcalcifications and are the imaging target the microcalcifications are the imaging target in most of these cases. There is a potential relationship between flat epithelial atypia, atypical hyperplasia, and a low-grade carcinoma. So people have looked at this, and they have very similar molecular alterations. So it's probably columnar cell lesions are probably a non-obligate precursor for the low-grade neoplasia pathway. And this is a few histologic pictures here of columnar cell change. You see you have one epithelial layer, some snouting here, and then this looks a little bit different. There's a stratification, so you have more cells than one, and this is a bit atypical, a little bit. It's not nicely oriented like this, so this is a case of flat epithelial atypia. And flat epithelial atypia is frequently associated with ADH, low-grade DCIS, tubular carcinoma, or lobular neoplasia. And in a recent meta-analysis, patients have shown a discordant results about from 13 to 67% of upgrade, right? But these studies, again, they didn't have a very strict radiological pathological correlation. This was a study that had 50 cases of flat epithelial atypia, which they observed these patients. They didn't do a subsequent excision, and none of these patients developed carcinoma during a median follow-up of 5 years with a very careful and strict pathological radiological correlation. So if all calcification, because these lesions are the target of microcalcifications, so if all these calcifications are removed, the upgrades are actually very low. They're sufficiently low for these patients to be offered observation rather than a surgical approach. So the WHO group recommends obviously a radiological pathological correlation, and if you have no other indications for excision, observation of these patients, it is an acceptable strategy. So you can watch these patients if you have concordant radiologic concordance in radiological pathological correlation, and you have no other indications for excision. And these are the data when you look the studies more carefully. In terms of papilloma, there's a spectrum of morphology. You have benign intraductal papilloma. You have papillomas that are associated with ADH or DCIS. You have encapsulated and solid papillary carcinomas. And of course, patients you have atypical papillary lesions or papillary carcinoma on core needle biopsy that should be referred for surgical consultation and excision. But the most commonly and problematic is what do you do when you have a single benign radiological concordant papilloma. And this is a classic case of intraductal papilloma where you have these fibrovascular cores. They're lined by a few epithelial cells that are pretty, they don't look atypical. So this is a very classic case. So there was a meta-analysis done for 34 studies that they have studies from more than 15 years ago till very recent, that the overall pool underestimated rate of malignancy was about 15.7% for non-malignant papillary lesions in cord needle biopsy. The upgrade for benign papillomas were about 7%, or atypical papillary lesions were about 37%. But it's actually pretty interesting. If you look at the data more carefully, you see that the underestimated rate for benign papillomas after 2005 was actually much lower, because we actually use a larger goat's needle, or we have a change of threshold in terms of the pathological diagnosis. So there was a difference of the estimation upgrade rate after 2005. But if you look at the data more carefully again, so there was the paper from Swap and colleagues here. They have 224 benign, radiologically concordant solitary intraductal papilloma that about 77 were excised. And of these, actually, they didn't have any upgrade whatsoever. And then there was another paper that they had 46 cases that they measured less than 2 millimeters, the so-called micropapillomas, that they didn't have any upgrades either. This was a relatively recent study where it had about 146 papillomas that they measured less than 1.5 centimeters, and they didn't have any upgrades on papillomas either. So if you actually put the study together, the risk of concordant, single benign looking concordant, radiologically concordant papilloma is actually, the risk of upgrade is between 0 and 4% the next three to 5 years. And this was a case that has patients who had radiologically concordant papilloma that were evaluated in a bi-weekly multidisciplinary conference, that they recommend surveillance for benign papillomas, that they had either ADH less than 2 foci, or they had LCIS, or they had ALH, and these were inclusion criteria, and they recommend surveillance. And actually these, they had a very low rate of upgrade. I told you about the study of for ADH. Now this was the TB-CRC 034 study that the data came out last year, that they looked at this study, and the main finding was that the upgrade rate for a papilloma without atypia was actually as low as 1.7% based on local pathology review. So that's pretty low. So the data show that the absence of any other indication for excision, if you have a single papilloma without atypia and it's radiologically concordant, or if it's less than 2 millimeters, so-called micropapilloma, you can observe these patients rather than followed by excision. The risk of patients developing breast cancer in the lifetime, these were 2 large case control studies of open biopsies. So the relative risk was about 2. So that actually is similar to other proliferative diseases without atypia, and that is the lifelong risk. But the risk of upgrade, as I showed you in the previous slide, was very low in 1.7%. This is a typical example of radial scar. We can see here fibrosis. You have entrapped epithelial elements and adenosis here. And this can actually be misdiagnosed in invasive carcinoma. Somebody hasn't seen a lot of these. The data show that if you have a very careful radiological pathological correlation, again, the upgrade to carcinoma, if you get a diagnosis of radial scar, is less than 2%. So that is pretty low. This was a meta-analysis. They show 49 studies, a pretty big meta-analysis, more than 3,000 patients with radial scar, that they showed the upgrades was about 6.7%, most of them being a DCIS. But if you look the data more carefully, there was a subgroup analysis where patients with radial scars, that there was no atypia whatsoever, they had a vacuum-assisted biopsy, and there was a concordance with radiology. The upgrade rate was less than 1%, which is in contrast with radial scars with atypia, with the upgrade rate, it was very high. So this was a 44-year-old woman who was recalled from screening with a digital mammography because they found an obscure 1 centimeter oval mass in the right upper quadrant. And then she had a diagnostic mammography with tomosynthesis that they found this lesion here was a ill-defined 3 centimeter lesion with architectural distortion. It was a BI-RADS 4B. So a stereotactic biopsy was performed that they show this fibrosis here and entrapped epithelial elements, which was consistent with a radial scar without atypia. So the question is, what do you do? I told you the upgrade was less than 2%, but the key here is that there was a discordance between the pathologic findings and the mammographic findings, right? This was a big lesion, about 3 centimeters, with architectural distortion. It didn't fit, so there is a discordance between getting the radiology report, the pathology report, and what you see mammographically. So due to this discordance and the limited sampling, this patient may be referred for surgical excision to make sure that it doesn't have something else. So data for radial scars, that there are less than 5 millimeters. They have a very low upgrade rate. And if there's concordance, we can watch them. Some experts recommend if you have a large scar, more than 1 centimeter, you should excise. But others have not observed the correlation between size and upgrade. And of course, size in radial scar is a bit tricky because it's how do you measure, because these lesions have irregular contours, right? Irregular contours in imaging, irregular contours in pathology. So the size is, if you put 10 people and say, what is the size of radial scar, you may have a quite significant inter-observer variability there. So that is a problem when you talk about size in scars. So the truth of the matter is that this time there is no consensus in terms of how do you manage radial scars. But I think most people, if you have an incidental radial scar that is less than 5 millimeters and is concordance with radiology, I think these patients can be offered observation rather than surgical excision. But if you have larger radial scars and associated with atypia, then these patients should be excised. Mucocele-like lesions, they are lesions that they have mucin extrusion, right? Into the breast stroma, usually adjacent to a cyst with mucinous contents. So this can be detected because the patient has a mass or because the patient has calcifications. And they're relatively uncommon, and because of that, there are no large series with long-term follow-up defining the cancer risk associated with these lesions. So when you get a diagnosis of mucocele-like lesion, the major concern when you get that diagnosis in core needle biopsy is if you have a partial sampling of mucinous carcinoma, you just haven't sampled that with the needle. For this reason, many experts now recommend excision of mucocele-like lesions diagnosed of core needle biopsy based on regardless of the presence of epithelial atypia. However, if you actually look the data more carefully, in patients with have a very careful radiological pathological correlation, the upgrade rate is less than 1%. It's very low. So when is the chance to underestimate, and you have patients with to underestimate the possibility of malignancy is with patients have a palpable mass, and you have a limited sampling with a core needle biopsy, and then there's a danger that you actually underestimate. However, if you get a concordant, again, you heard so many times this word, a concordant radiology, and you get a mucocele-like lesion, doesn't have any atypia, I think these patients can be, the data show that this patient can be safely observed, but you have a low threshold for excision if you have any changes radiographically. So if your patients get a diagnosis of ADH in your breast core needle biopsy, these patients should be sent for surgical consultation and excision, unless you have a very small focus of ADH and all the calcifications have been removed. There's a small percentage of patients that you can discuss with them the observation, but the great majority of these patients should be refer for excision. Patients who get a diagnosis of ALH only, they can offer surveillance. Patients who get diagnosis of LCIS, they can classical SCIS, they could be offered surveillance. If you get non-classic variants, these patients should be referred for excision. If you get a diagnosis for flat epithelial atypia, these patients can be offered surveillance. Excisions could be discussed with the patient if there are residual calcifications, but if everything is removed, I think these patients can safely be offered surveillance. If you get a papilloma that doesn't have any atypia and it's concordant with the radiologic findings, these patients can be offered surveillance, and especially if it's too small. If you get a diagnosis of radial scar which doesn't have any atypia and it's small and is concordant, these patients can be offered surveillance. They don't have to be excised. And if you get a diagnosis of mucocele-like lesion without any atypia and concordant radiology, these patients can be offered surveillance as well. And there is a lot of studies. We're trying to how can we do less surgical excisions safely in these patients, and there is ongoing trials to try to actually see which patients can be offered surveillance with DCIS and not surgical excision. We'll see what comes out of that. So the accumulating data that show you on core needle biopsies show that after careful radiological correlation, which is imperative, suggests that not all patients with atypia require surgery. Many of these patients can be safely observed. And it's often overlooked that the impact of core needle biopsy diagnosis for these non-malignant breast lesions and the ongoing interventions in patients' lives is very important to them. And I think it's frequently it's been overlooked. This is my email. If you want to email me, I'm happy to answer. And that's what I have for you. And thank you very much.